want to study hard and do well in life. It experiences as a lot of apprehension, feeling uneasy, feeling like dreadful, like, oh my gosh, I have to do this or that. Sometimes, growing up in school, you're always asked to do like, verbal presentations, oral presentations in front of the whole class, and everyone gets really upset about that. And you're like, oh my gosh, it's going to be the end of the world. But it's the anxiety preparation for that is why you prepare so much to do that. So a way to warn a person of a threat, conflict, or danger. Okay, so if you're going into a bad section of the city or something like that, you might lock your doors, you might be more observant, and things like that. That anxiety is out to help protect you. It affects at a deeper level than fear. Okay, so it's like one step above that, and that anxiety is like how your body's portraying your response to that specific situation. It should be noted, and you should underline this, that anxiety is a subjective experience of an individual. So when we talk about anxiety versus fear, fear has a specific object the person is considering, and fear produces the anxiety. Anxiety is the most common mental illness in the United States, with a prevalence rate of 18.1% of the entire population, and of that population, only 36.9% actually receive any treatment. So let's talk a little bit more about fear. Because I can explain that cognitive process is that reaction to a threat, okay? But this is what produces the anxiety. And someone, like a person, is then fearful of that something, okay? Fear is an emotional response to a known threat, and when faced with fear, most people will experience the physical reactions that are described under anxiety. There's 4 different levels of anxiety. First 2 we're going to talk about are mild symptoms. And in the mild symptoms of anxiety, you should know these mild symptoms that express those feelings of restlessness, starting to bite your nails, start being fidgety and restless. And I'm sure you've noticed this on the units where you've been working with somebody you've been talking to. Look at their legs, they're going like a mile a minute. Look at their hands, they're fidgeting with a pencil. They're tapping on that's mild anxiety because there's somebody new that they're talking with. You could look in a mirror the same way. You might be a little bit nervous talking to somebody, and you might feel more fidgety as well. There may be an increase in the perceptual field, and it promotes learning and or creativity, okay? Because you're more open to doing different things. Moderate level of anxiety is when you start noticing your heart rate start to race, and the pulse and everything starts to, your heart rate starts to race, and then that GI upset, like you're like, oh my gosh. Maybe if you're going to do a presentation or you're going to do some type of show or some kind of thing in front of people, you get that gut feeling like, oh my gosh, I suddenly get upset, GI upset. Increase in sweating and increase, notice you have to go to the bathroom like every 20 minutes, right? Like that constant feeling like, oh my gosh, I got to go to the bathroom. Now is when that perceptual field starts to narrow and you start to really get selective on what you're thinking or what you're doing. You get zoned in, okay? And then you can start to attend the learning situation. But write this down, that the physiological response associated with anxiety are all modulated by the autonomic nervous system. Because everyone knows what a beta blocker is, right? right? Helps slow down your heart rate. Does anybody know a fruit that automatically is known as a good beta blocker? It's in general like for stage fright and things like that, or going out and performing and things like that. A lot of performers eat this type of fruit before their big performance because it's more of a natural beta blocker that helps them calm down. Does anybody know what this? It's easy to remember. Think about beta blocker starts with a B. This fruit starts with a B. Yeah. Banana, right? So they consider that the natural beta blocker. You don't have to write that down, but that's just something interesting. That a lot of performers will eat like 2 bananas before they go out and like comedy acts or we're going in front of a stage or performance because they want to calm themselves down. All right, so then we have severe anxiety, and this is where you start feeling nauseous and you can't sleep anymore. Those hand tremors start to feel a bit more intense, and then you feel that impending doom. You focus on one detail as opposed to, that narrowing. Now you're narrowing that even further. And you have a hard time solving problems. So as a college student, I don't know if you've ever experienced this when you're taking a test where you get yourself so worked up. At the beginning of the exam, you start thinking to yourself, oh my God, you get that impending doom. I'm going to fail this test because I didn't know this answer. And then it starts affecting your confidence level and then eventually affects your ability to answer the questions appropriately, right? So when you get feeling like that, you step back and you be able to kind of relax before you proceed with the exam. Because sometimes you get yourself so worked up, and then after the fact, you're thinking, what was I thinking? Why wouldn't I just answer this? I knew this question. But at the time, that severe anxiety took over, and you're not able to answer questions the way you normally would. And then a full-blown panic attack. And this is where you start pacing, you start withdrawing from others. At times, you can experience hallucinations and false perceptions. So someone that comes into the hospital, into the emergency room, and with hallucinations, our mind always goes to, oh my gosh, this patient's struggling with schizophrenia. They're psychotic, they're delusional. Perhaps they're just having a panic attack. So don't jump to conclusions that someone that is having hallucinations or not thinking clearly is psychotic. Because as we know here, that in panic attacks, you can start thinking irrationally. Okay. And then you're not able to really process what's really going on in the environment, really what's going on where you're at, because your mind is just so off. Okay. So types of anxiety disorders we're going to discuss. We have separation anxiety, phobias, social anxiety disorders, panic disorders, agoraphobia. Generalized anxiety disorder is quite common. Anxiety disorders due to certain medical conditions, right? Or different substances you use. OCD, body dysmorphic disorder, hoarding disorder, trichotillomania, scoration disorder. So there's a lot of different anxiety disorders. Rather than just saying this patient is anxious, it's really important to try to find out what type of anxiety disorder they fit into. So let's talk a little bit about what this means as far as what's causing this anxiety. We did talk about serotonin for depression and dopamine and norepinephrine. But I want you to make sure, and I want you to be aware of, that there's many more, hundreds more neurotransmitters out there. We've just focused on those 3 for now. We're going to add another neurotransmitter. We're going to talk about GABA. And when you think about GABA, you think about anxiety. And GABA is an inhibitory neurotransmitter, okay? And basically, it decreases the likelihood that the neuron will fire at actual action potential. So it's inhibitory. So someone with anxiety has problems with their GABA, the neurotransmitter GABA. The limbic system, which includes many more things than just the amygdala and hippocampus, but in those areas, we're talking about the emotional part of our brain. The limbic system is our emotional part of our brain, explaining rage and fear, arousal, memory. So just know, and you can underline this, that just know that anti-anxiety medications act on GABA transmission. Okay? Now don't get me wrong, they do have an impact. SSRIs used in these types of situations long-term is the way to go, increasing serotonin. But just know when you think and hear anxiety, always think GABA. Now, there's medications that can help with the GABA, and that is, benzodiazepines and things like that, and we'll talk more about that. But understand that when we're talking about these benzodiazepine medications, traditionally they are more of a rescue medication. Somebody that's experiencing a breakthrough in symptoms would take a benzodiazepine like Ativan, Klonopin, Xanax, right? And they are very, very helpful, okay? But you really, really want to limit these medications in patients that have substance abuse problems, okay? Pregnancy, for example, also. And you don't want to use them long-term. So we did discuss this, I discussed this with somebody in my clinical group, with someone that was, had a history of substance abuse problems, and we're talking about medications to maybe why they're on certain medications. What is a good medication to help with anxiety with somebody that struggles with a history of anxiety, or a history of anxiety, but also substance abuse problems, and they've been through recovery and they don't want to relapse? What would be a good medication? Huh?
Boost bar?
Yeah, whoever that was, thank you. Boost bar. Good. Boost bar is great for that, and they're aware of it too. And they're aware that boost bar is a good option for them because it's not going to cause them to feel any dependence. So, we're going to talk about norepinephrine. We know norepinephrine is that fight or flight response, and it's found in that locus coeruleus, which produces the norepinephrine, and pathways are then connected to the amygdala. Think of the amygdala as your just fear center, as like that's where all the fear and that's where all the emotions are. Like that's where a lot of that anxiety coming from. Onto the hippocampus and also the cerebral cortex. So when we're talking about how to treat these symptoms and how to lower that activity, because think about it, if we're going to jack up the norepinephrine, right, in medications such as stimulants or tricyclic medications or SNRI medications, that could really bring on some of that anxiety, okay? There is belief that serotonin has an impact on anxiety as well, and we do know that we'll learn a little bit more that SSRIs are your go-to medications for long-term treatment for someone with anxiety. So what does GABA do as a neurotransmitter? GABA controls the firing rates of neurons. And when GABA crosses the synapse and attaches to its postsynaptic receptors, the ions are exchanged, and this decreases the cell's excitability. So GABA is more of that chill out, right? Calm things down. So it definitely slows the cell activity down. So it's hypothesized that people with anxiety have that problem with the efficiency of using that of the gamma. Okay. Studies suggest often that anxiety disorders run in families, just as depression would, just as any other mental health problems would. And looking at the effects of genes on the development of PTSD, why do some people exposed to trauma develop PTSD and others don't? Okay, the hippocampus appears to be smaller in some people who are victims of child abuse, right? So always think about that, the limbic system as like your emotional portion of the brain. Now, cognitive theory of where this is coming from, sometimes our thinking becomes very distorted, okay? Our thoughts become distorted. And then, which relies, then by having our thoughts distorted, the person really starts to feel vulnerable. Hence, the anxiety increases going forward. So a person experiences fear in response to something. When they avoid something, they feel less anxious and learn to avoid that certain situation. So it's like somebody with PTSD may avoid going to the movies to watch a movie about war or something like that, because they know that they know what their triggers are. So that anxious response role is modeled in a sense. The psychodynamic theory talks about avoiding those aggressive feelings and anxiety, and understands that anxiety leads to an overuse of ego defense mechanisms. Those ego defense mechanisms are used to decrease anxiety and become maladaptive with excessive use. Reciprocal anxiety. Understand what this is, okay? It's the reaction to spending time with somebody who has that increase in anxiety. So you're going into your clinical rotation and you're going to talk to somebody that's extremely anxious. You're not anxious yourself, but you're talking to them. What happens is reciprocal anxiety is when you sit and start talking to them after 10 minutes, you notice you're becoming anxious just by being around them, okay? Let's talk about how the terms and defense mechanisms that we use when it comes to anxiety and dealing with anxiety. So we have compensation, we have denial, dissociation, okay? You have all these, I'm not gonna go through all of them in detail because you can see them in your book here, but these are the defense mechanisms, and make sure you have a good understanding of the defense mechanisms. I may pick like maybe 2 or 3 different ones and kind of have them on the exam to make sure you have a good understanding of them. So let's just kind of look at some other different options here. So if you're as far as displacement, okay, this is the transference of emotions associated with a particular person, object, or situation to another non-threatening person, object, or situation. So you're displacing those feelings. Then compensation is used to, talk about like the perceived deficiencies by emphasizing their strengths. So like, you want to make sure you're compensating by saying, well, this makes me extremely anxious, but I do very well in these parts. Like I can do these things. So you're trying to use compensation. So separation anxiety, concerns over being away from a specific person, anxiety about separation, sleep problems, nightmares, headaches, GI disturbances. So it's not uncommon working with the children and adolescents that when they come into the hospital, they digress even further when mom and dad are no longer Picture being 10 years old and sent to a hospital where mom and dad are no longer there. You're sharing a bed with somebody, sharing a room with somebody else that you don't know, you don't feel comfortable with. You're not at your same bed. You don't have your own routine. So a lot of times patients will digress in that situation and have that separation anxiety. Where's mom? Can I talk to mom? Can I talk to mom? Constantly. That clinging, that needy feeling like I need my mom, I need to do this, I need to do that. I usually sleep with my mom all the time, and now I have to sleep in this bed. And as far as in adults, there's a lot of worry, feeling shy, feeling tired, having no self-direction, and not able to do things on your own. You begin to find yourself being attached and always needing to be by mom and dad, even though you're an adult. So you can get a lot of separation anxiety there. Now, briefly, we're talking about phobias. A persistent, intensely felt irrational fear. Important part of this is irrational fear of a specific object, activity, situation that results in a compelling desire to avoid the feared stimulus. So, phobias of many different things. We'll talk about. One thing you should really know as far as there's so many different phobias, it's unreal. But so spiders is arachnophobia, snakes is ophidiophobia, heights, acrophobia. So I'm not going to hound you on like knowing all of you can look all these up, and there's no sense in you memorizing or wasting time with that. But I want you to be aware that really some really bizarre phobias, like phobias of like paper clips, or phobias of like a different weird, strange things like you'll get, and it's like what, and it boils down to a irrational fear. Why would you be so worried about these things? But trust me, if there's a phobia, there's a phobia for many things. But we know mostly like arachnophobia with spiders and things like that. But know that there's many different options. Social anxiety disorder, or like we're talking about social anxiety disorder, we're talking about like social phobia. So this is that persistent fear of being in social situations, or performing anxiety. I think a good majority of people don't like to stand up and talk in front of a bunch of people, but this is to a whole new extent, okay? These patients that struggle with this, they understand that their fear is like way out there, and they understand that their fear is irrational, but still, they still can't, they still struggle with it. Being around new people, meeting new people, that anxiety level just increases tremendously. Some people, just the thought of being in a room with people that they don't know sends them from a mild state of anxiety to a sheer panic attack. It's important also to understand the duration of this. If someone says that they have been struggling for the past 3 months, because they have not been able to go and socialize with others or make new friends or things like that, it's not considered a social anxiety disorder until you do this for 6 months. Okay, the duration is key. A good example is struggling to attend a party where they are forced to talk about current events or non-work related issues. So a lot of times people will compensate by going around in different situations, specifically talking about their field of work or something like that, because it's a compensation. Like you can talk about work, but it's very difficult to talk about anything else in my personal life or talk about anything in that aspect. So panic disorder, men are a little less at risk for panic disorder. It's 2 to 1 as far as the ratio between male and female. And not everyone who experiences a panic attack will develop a panic disorder. But the key is that somebody that struggles with panic disorder very likely will have a history of depression. Okay? Because think about it, all those symptoms you experience about panic situations are terrifying, and who wants to really talk about that? Who wants to really? It brings you down to the fact where what happens is you tend to isolate a lot, not go places because of the fear of you having a panic attack. What happens if it happens again? Do panic attacks, they come out of nowhere? Are they triggered? What do you think? Most panic attacks, are they, is something bring it on, or they just come? Does anybody want to guess? Has anybody known anybody or experienced panic attack or familiar with panic attacks? No one knows anybody with a history of panic attacks? Exactly. Sometimes it's triggered, but the majority of the time, patients are just sitting there and doing their thing, and it just comes about. It could just be. It just doesn't have to be a specific trigger as far as what caused it or anything like that. I do encourage you to, if you don't really know anybody with panic attacks, when you're talking about somebody in clinical who has a history of anxiety, ask them what happens when they experience a panic attack and what's going on at the time. Majority of the time, it just comes. Okay. So what do we got criteria-wise if we're going to have someone with a panic attack? Before we go on with this though, if you're going to be talking to somebody, how do you talk to somebody experiencing a panic attack? How do you express, like, if I'm having a panic attack, what is it that you're going to talk to me about? How are you going to approach it? So you're in the unit and you see somebody going through a panic attack. What are some things that you can do to help calm that patient? Yes. Right. So what kind of technique is that? Distraction is more like a mindful technique too, because you're someone. I challenge anybody who has trouble like falling asleep or something like that. You're constantly thinking to yourself, oh, you have a lot of thoughts in your mind, and you have a hard time bringing yourself back down because you're like, oh, I got to do this tomorrow, I got to do that tomorrow, I got to do this tomorrow, and that's what's keeping you up. Similar to somebody that has a panic attack, whatever is causing that panic attack, whatever they're panicking about, whatever they're feeling anxious anxiety about, they're focusing on a loop with that. So you coming in and saying some different senses of what do you see, what do you smell, tell me this, tell me that. Perfect, because it helps you more of a mindfulness kind of thing. Well, if you're tracking your mind on, I'm here in the classroom, I'm going to count everyone here have like grounding techniques too. Like I'm going to count things around me. I'm going to count the tiles in the wall, and I'm going to count this and this. So you can help them with that too by saying, how many desks have in this office here or in this room here are not for use. Tell me how many different. What do you see that's green? What do you see that's? And what's going to happen is they're going to take their mind, because they cannot do this. They cannot continue to think about what's causing them to be stressed out or anxious or extreme panic attack. They can't continue to think of that and do the task that you're asking. When you do that task that they're asking, they're taking their time and taking their energy and moving it and shifting it to a task. 1, 2, 3, 4. And when you're doing that, you're taking it away from that. You can't do two things at once. And grounding techniques are very helpful for that. But overall, you want to make sure you're using a very firm, short, and simple statements. You're not going to have a full-blown conversation with somebody in a panic attack. You got to be concise with what you say. Because everyone here has been times where your mind has been preoccupied, and someone either talking to you sounds like wah, 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 wah. You're not getting any of that. So be very direct, firm, and short with your statements. All right, so criteria for a panic attack. You have to have that discrete period of intense fear and discomfort in which 4 or more symptoms develop abruptly and peak within 10 minutes. General panic attack lasts about 10 minutes. You have the 10 symptoms that you're really looking at, you want to have 4 of, or the symptoms that are outlined here that you want to have 4 of, include heart palpitations. And when I say heart palpitations where you feel like your heart is going to beat out of your chest, feeling really sweaty, feeling a little clammy, trembling, those feeling like you're smothered, feeling like you just can't get out, okay? Choking sensations, chest pains, nausea, feeling dizziness. People that have extreme anxiety often, a lot of times, feel that they're having a heart attack. And this is where it gets tricky, because you get to know somebody that has a history of anxiety, right? And they feel like they're having a heart attack. But if you went to the doctors every single time that patient stated they had anxiety with feeling like they have a heart attack, you may have like 32 EKGs done in your in a month, right? You have that nausea, feeling dizzy, derealization, not so sure what's going on, depersonalization, feeling that you're just going to lose control. You fear that you're going to die. People going over bridges and things like that, I've noticed sometimes, where, I don't know if you ever noticed this, maybe I just do, but when you're going over bridges, you'll always look to the side and you'll have like those cars with the flashers on, like on the side of the road. That person or somebody in that car is experiencing extreme anxiety about going over the bridge, especially the big, huge bridges. So there's a lot of different things going on. And when you're talking about depersonalization, that's where you're talking about that feeling of being like things are just unreal. Things aren't real around you. You kind of lost your sense of identity, okay? And this is very unique when you're talking about somebody with a panic disorder. Understand that, okay? Okay, so then we have that anxiety, agoraphobia, the anxiety about being in places or situations from which escape is very difficult. Anytime you're in like a club or something like that, or you're in a bar, you're maybe in the middle, there's a lot of people. Those are the people that are always looking for the exits. Those are the people that are always looking for, how am I going to get out of here? Someone in that situation, you start hyperventilating, you feel like you're losing yourself, you can't get out. Situations are avoided or endured with distress. So examples such as like those public transportation, getting on think about it. Think about what a subway is. You're getting in a little capsule underground, and then you're going underground in a little capsule filled with people you don't know. That's a little, in general, for people who don't have panic disorder, things like that, that's terrifying. Being around in open spaces, or being outside sometimes, or standing in lines or different big crowds. So a lot of people struggle with big crowds, right? Just because of terrorist attacks and things like that, about being in tall buildings and things. So things that happen in our life, or things that we have witnessed in our life, can also contribute to why we might feel so anxious, right? Generalized anxiety disorder. You're probably going to see this probably most in the clinical setting where you're at, as far as a diagnosis. So generalized anxiety disorder affects women also, greater 2-to-1 ratio. Why do you think that is? Why do you think it's always women 2-to-1 ratio as far as these anxiety disorders? Do you think men don't have as much anxiety as women?
Is it just men report it less than women?
Exactly. That's my stance on it. I think it's not very manly for somebody to go to the doctor and say, "Listen, I'm got a lot of anxiety and stressed out," and things, because they're always kind of programmed to just keep on going and be a man and suck it up, right? Same thing with the depression as well. This can develop anytime throughout your entire lifetime. So it's like not so much, well, if you got by your college years without any diagnosis of anxiety, meaning that you're scot-free, that you're not going to have any problems going forward. This could happen at any time. But it is the highest risk during childhood and through middle age years. We did talk about, before even starting the whole lecture, about how it's so comorbid with other disorders. I really highly, highly doubt you're ever going to be meeting somebody on your inpatient units that has a diagnosis of anxiety and anxiety only. Okay? That's not going to put you in the hospital because you're anxious. It's going to put you in the hospital because you're suicidal and you have a comorbid problem with anxiety. I would also like you to count how many times someone has anxiety and someone who has depression and does not have a comorbid diagnosis of anxiety. Comes hand in hand so often. So we're talking about generalized anxiety disorder. This is where you have that excessive worry more than not for at least 6 months. So we know with depression, in order to get the diagnosis of depression, it's 2 weeks, right? But if someone wants to get a clinical diagnosis of generalized anxiety disorder, you have to have that excessive worry more than most days for at least 6 months before you consider a diagnosis. These people have a hard time controlling their anxiety and worry. And often these patients struggle with anxiety over one specific topic, right? And then as you go and that anxiety starts to lift, you find yourself on a new different topic you're worrying about. Now I'm worried about passing this class. Now I'm worrying about finding a job. Now I'm worrying about where I'm going to, all these different transitions in life is where you're going to start having these consistent worries. So this one worry here may not be the same thing you're worrying about 3 months from now. You'll pick something else up you start focusing on. It's accompanied by at least 3 of the following symptoms. And that would be fatigue, feeling restless, inability to concentrate, and circle this one and highlight this one, irritability. Okay, you think, why would somebody that's anxious feel irritable? Okay, it's that low frustration tolerance, that I'm going to lash out at you, right? Same thing with depression as well, to get the irritability. Muscle tension, can't sleep. You have to also look into other different disorders or medical disorders that are quite commonly presenting as anxiety. And does anybody know what the number one thing we find? I wouldn't say often, but we find sometimes in lab work that someone who's extremely anxious is also carrying this medical diagnosis. Take a guess. Yeah.
Is it a UTI?
Not what I was thinking, but it's an option. What else? It's a good option. What else? Think about it. Okay, if you're anxious, my heart is racing like crazy. I cannot sleep, cannot eat, or if I eat, I'm still not gaining any weight. My hands start to tremor.
Hyperthyroidism?
Yes. Hyperthyroidism. Think about it. Hypothyroidism is going to cause your depression. Hyperthyroidism is going to cause your anxiety. So think of that as someone specifically has no real problems with anxiety in the past and now all of a sudden presenting with all those symptoms of anxiety. Okay? You could just jump to the conclusions and say, okay, they're anxious, or you can kind of rule other things out, because if you give them, treatments as far as their thyroid, like iodine or something like that, to help with reducing the thyroid and finding out what's going on there, you solve that, you solve the anxiety symptoms. You're not gonna get anywhere by giving them any medication to help with their anxiety if it's not stemming from a mental health problem. Okay. Note that these symptoms can also significantly cause a lot of distress or dysfunction in their life. So here's some different things you want to look at. Know the symptoms of GAD, okay, what we just talked about. We talked about fatigue, restlessness, decreased concentration, irritability, tense muscles, and sleep problems, okay? And know that irritability is an affective manifestation of anxiety. What can I see in somebody that I know they're feeling anxious or have a strong likelihood of feeling anxious? Irritability. So different conditions, medical conditions we're going to look at: cardiac, endocrine, respiratory, neurological problems, anxiety disorders. We're talking about different substances. You can read all through that long list of substances that you want to rule out somebody is on when you're thinking about somebody that's anxious. Okay? Always think about what other options could there be of why they're presenting to be anxious. Don't just jump to conclusions and say, this person presents as anxious, I bet you they're anxious. We know that. We got to find out where that's stemming from. OCD. In between men and women is quite equal. 1/3 experience the first symptoms when they're a child. This tends to run in families, as do a lot of mental illnesses. And also in childhood trauma, it would increase the risk of OCD. The course of the illness varies, and the severity of this illness varies. If somebody has to do certain different things, I need to check the oven 4 times before I leave the house, and you do that, and that's all you're dealing with, check the burners. So I'm gonna go through and check all the burners, check all this, check all that. Good. And I'm on my way. And that took about 20 seconds. They might not require as much treatment. However, there are times where kids or adults, I can give you an example with kids, is that they needed to do a ritual, and their ritual might be an hour and a half long before they were to leave their house, right? So they're being late for school, they're not attending school because they have to do it all over again. I know I worked with a girl who, when they went to school, would not step on any cracks, so she was going through the whole, going back and forth in the hallways, doing that, okay? It's debilitating, I think to a degree, some people do this just as habits. If you watch anybody in like sports or something like that, I know baseball players are always about like checking to doing a thing. If they're they have to do an exact certain way of doing their thing, more like a superstition kind of a thing. It doesn't take away from your quality of life. It's really not considered OCD, right? But if it's really taking away from your work and about getting things done, then it's a severe problem, and you need to reach out for help in that aspect. So these disorders can be recurrent and persistent. and they consist of obsessions or compulsions. The person will recognize that the thoughts and behaviors are definitely excessive. They'll tell you that. I know I should not be tapping on my pencil 45 times before I can go to the next room. I understand this, he says, well, but I can't stop doing it. Okay? And the obsessions and compulsions cause marked distress in their ability to function. Okay? These are the kids that just simply say, without doing any of these routines, I'm not doing them today because it's going to take forever. I'm just not going to go. I can't do it. Right? So what is an obsession? Obsession is that recurrent and persistent thoughts and impulses or images that are very intrusive, inappropriate, and cause distress or anxiety. When we talk about intrusive, or we're talking about obsessions, we're going to talk about they are not simply excessive worries about real life problems. The person tries to ignore them or kind of neutralize their feelings associated with them, and recognizes that these thoughts are more or less coming from your own mind. It's like a product of your own thoughts. Now, compulsions, however, these are those repetitive behaviors that a person feels driven to perform. Okay? I have a compulsion. My compulsive thought is that I cannot leave that room unless I do 20 jumping jacks, right? So the behaviors are done to decrease some of this, like some kind of would happen. What if I don't do that? Something may happen. So key to know and understand is that in OCD, stress will worsen your patient's thoughts, images, and impulses. So a kid with OCD who went through the whole summer without many major problems with their compulsions, and when they're starting to ramp up back for school, you're going to see a lot more because that's stress. Or if you're going to have that child do something out of their routine, it's going to cause stress, and you're going to see more and more compulsions and things like that. If you're going to treat OCD, do you know what therapy they use for OCD? And don't say CBT, because that's the answer to 99% of the other questions. CBT is great, but not for these kids. It's what is it? Anybody? Exposure therapy. That's when you walk with a therapist who's afraid to cross the bridge. You're going to walk with the therapist, and we're going to do it. We're going to walk across the bridge. And that's the idea of getting to the other side, realizing that nothing bad has happened, to program their brain to say, got it, I can do this. But it's a delicate process, and it's time-consuming, but very effective. Okay, so next thing we talk about body dysmorphic disorder. In a body dysmorphic disorder, this often develops in adolescence, slightly higher in women than in men, and this is that exaggerated belief that your body is just, there's just something wrong with you, when really, there is nothing wrong with you. These are the people that get plastic surgery upon plastic surgery to bring out these abnormal, the things that they feel they're abnormal, these defects. Repetitive behaviors are focused on the anomaly, like, oh my gosh, my ears are too big, I need to get them, resized or whatever, and then you go through all that process, and part of the problem is these plastic surgeons that agree to do these surgeries because they're making money, but it's like you're feeding into these people that are, oftentimes just feel so bad about themselves. So why do people like this feel so bad about themselves and have that low self-esteem? You're going to have definitely a high rate of depression and increase in suicidal risk for these clientele. Also, they oftentimes have a history of neglect or abuse. or they are risk for simply because of their poor self-image. So somebody, you want to know this, somebody that has excessive behaviors associated with body dysmorphic disorder. You might see somebody excessively grooming themselves and excessively checking their mirror and seeing how they look before they go places. We all, get ourselves ready and things like that, but this is to a whole new degree. Hoarding disorder, made famous now by the Hoarding show on TV. A lot of people kind of get more education from that, and then they kind of have a better understanding. But these are the people that will not discard any items or anything like that because there's a strong urge to save these items. And these items are trash. This could be a wrapper from a hamburger that you got that they cannot part with. I cannot throw that away because I got that on this day or that, and they have a strong connection to it. And it's trash. Their house is just a cluttered mess, and they may or may not be aware of the problem. A lot of times they're not, because they feel that this is normal for them. And why are you coming into my house telling me how I should live? This also is passed down in families, and there's a lot of comorbidity with depression and anxiety with these types of disorders. Okay. A lot of times, sometimes you'll notice that these families will start to collect all these things when somebody very, very close to them passes away. I can never get rid of anything of theirs because there's so much significance. And it could be a house full of stuff. This is because, I need to conserve this because we're no longer here with us. And that really flares up these hoarding disorders. Does anyone ever hear of trichotillomania? Yeah. It's quite easy to kind of find out. It's easy to kind of notice someone that has trichotillomania. The two spots that they really like to pick their hair from is their eyebrows and the top of their head. You'll see somebody that's like, wow, look what happened to their eyebrow. Like, they're actually pick their hair out. Because I feel like it's basically like a ritual. It's something that they do. It's like a constant kind of thing that they do for themselves to kind of pick at their hair. Sometimes when they're very stressed out. Okay. Risk factors for this include the family history. Of course, the genetics play a role in this. Anybody that, it can develop from any time through lifetime. Mostly between the ages of 10 and 13, you're going to see a lot of this behavior. Often you have that concurrent depression, anxiety, OCD-like traits. And stress is the number one trigger. So someone in school, someone that's going to take an exam, while someone's taking an exam, you notice they're just picking away. That's just their nervous habit, picking at their skin. Scoriation disorder is when you start picking the skin on your face or hands or arms. They're doing this without even thinking, without even knowing it. That same feeling where you pick a scab, you have a scab that's like you just want to pick at it, or it's like well, think of that as all throughout. Like, no, it's just your skin in general, they won't pick their skin. So when you're assessing for anxiety, you want to first off notice what level they're on. Remember the 4 levels we talked about? What level are they on as far as their anxiety? Do you want to have any history of suicidal ideations or self-harm? You want to look at their medical history, what not only their psychiatric history, but their physical history of medical problems and history of substance abuse problems. So there's different ways to assess your patient's anxiety. You're familiar with the PHQ-9 for depression, and you can move on to what's called the GAD-7, GAD-7. And that's going to be your version of your PHQ-9 to anxiety, okay? You can also ask them on a scale of 1 to 10, how anxious do you feel today? Something that simple. Don't forget that those who are anxious are most likely depressed as well. So you want to look into other means. It's rare you're going to find someone just with anxiety. It's rare somewhere you're going to, it's like depression and anxiety go hand, it's like hand in hand. What kind of issues did they have? What kind of medical issues do they have? They have any heart issues? They have complaints of dizziness, increased heart rate, tremors, chest pains, all those different things. So when you look at when you go into a full like medical exam, you're going to kind of look at with someone with anxiety. You're going to have a lot of people that have concurrent history of cardiac problems. If you're constantly tense, if you're constantly stressed out, that's going to have a significant impact on your heart. Okay. Endocrine issues, you're going to have those sometimes palpitations, flushing, skin, tremors. How does stress affect our GI system? Well, you're going to have a lot of dry mouth because you get that nervous, that kind of that dry mouth feel, feeling tired, tense. You get a lot of headaches. Okay. These are the patients that are a lot of issues that is chronic anxiety. Think of chronic medical problems as well. There's a lot of things you have to rule out with someone with anxiety. Okay. So to intervene here, we're going to talk about interventions if someone you already assessed for their level, okay, and you notice, let's say they're in the mild to moderate level. Well, you want to always continuously assess for their safety. You want to explore other questions by asking open-ended questions, get more information from them, and clarifying different things. You want to discuss problem-solving techniques, examine different coping techniques and relaxation techniques. Know your relaxation techniques. Know what you can do and what you can explain to your patients when it comes to relaxation techniques, okay? Because that's what they're going to want to hear. They don't want, it's one thing for someone to tell you all what to do or this or that or that. If you explain to them as something that they can do and can try, okay, it's going to be effective. Help the patient develop problem-solving options. So, give them a different things to choose from. And sometimes it might be helpful to practice some of these techniques for yourself so you can better explain to them and explain to them, hey, I've tried these things and these tend to work for me. You might want to give them a try. Don't ask anybody to do something you won't willing to do yourself. Severe panic attacks and severe anxiety. Well, these patients are really unable to problem solve all the time. So you're not going to be really educating them, okay? You're trying to assess their safety always. You want to make sure that they're really, you're helping them with their physical needs, and make sure your discussion with them is very clear and simple. You want to point out to them what is occurring. What I'm seeing you do is I'm noticing that you're really fidgety right now and you're having a difficult time catching your breath. Here's what we can try. Very small things. And take that anxious person and help them walk into their room or to a spot where there's not a lot of people. Same situation when someone's manicky or things like that. You want to decrease the stimuli. No one wants to have a panic attack in front of people. That's the worst thing ever. People are staring at me. What that's going to do is intensify my anxiety. You want to think about possible medication management. This is where those rescue medications like Ativan, Klonopin, Xanax would work well. And use a low-pitched voice and be firm. When someone is a full-fledged panic attack, though, you lost your opportunity for kind of medication, right? It's going to last about 10 minutes or so. You want to notice when you're starting to explain to them, like, where do you feel like when this is all over? A good thing to do is say, what is it that your body feels like when you're starting to realize that things are getting out of control? That's medication time. Not when I can't breathe, I'm fidgety, and I'm having a full panic attack. It's not like I could pop a Klonopin and be like 5 minutes after that be good, right? You lost your opportunity, okay? All right, so we're going to talk about treatment modules. We got cognitive restructuring, learning new behaviors, anxiety reduction. So when you're talking about, this is cognitive behavioral therapy we're talking. Reframing, thought stopping, examine alternatives, all those kind of black and white thinking. You want to make sure you're giving them alternatives and restructuring the way their thought process is. You want to learn new behaviors by the role playing and social skills training, okay? So when you start to feel a little upset, let's do this tense and relaxation muscle. Let's do it now when you're calm, so the next time you do it, you're going to be able to use this when you need it, and it may be more effective for you, okay? And anxiety reduction, has anyone heard of EMDR? Rapid movement of the eyes is when they kind of go back and forth, and with a therapy like this, and they kind of help you by doing this. This is a general, very, very basic explanation of it. It's much more complex. They'll get in front of you someone with PTSD, and they get your finger in front of you, and they'll go back and forth. You follow the tip of their finger, and then they start to talk to you about questions about the past and bring that up while you're talking about it and processing that with you. Whole idea is we were talking earlier about distraction. When you're distracting yourself and you're opening yourself up to look at this, it's kind of like more of a hypnosis type thing, where your rapid eye movements, it'll allow you to start processing some of these thoughts. Okay? It's called eye movement desensitization, and reprocess. Right? You're kind of rebooting your chronic thoughts and stuff like that from the past. Aromatherapy, guided imagery, meditation, progressive muscle relaxation. These are all different options you can offer the patient and talk to the patient about what they might be more willing to try. What the goal of the EMDR is that it really dampens that power and the emotional connectivity that you have to that thought. Whatever happened in the past that was traumatic, it's going to help lighten that up by doing the back and forth and starting to talk about it. Right, so moving on then, health teaching, you want to educate the client and the family, okay, about the physiological issues associated with the anxiety, the different triggers, know your triggers, know what makes me feel anxious, know what if I'm around, may trigger me. Different coping strategies, making sure they have a list of these. Every treatment plan and every safety plan should have coping skills on there, okay? Support groups, treatment options, and different treatable, and it is basically explained to them that it is a treatable condition, okay? Now, talk about medications. SSRIs, number one used for anxiety. Then you have the SNRIs, Effexor and Cymbalta. This is kind of a review. And then the MAOIs, forget about them. You're not going to see them much at all, so they don't really use that much. The benzodiazepines, Ativan, Klonopin, Valium, Xanax. What's the big deal? What's the big difference? Well, I can tell you that Xanax is going to be that most abused because it gives a very small window of opportunity to work. It's not going to take long. It's going to give you a jolt of it's going to be like a hammer, like, okay, you get it right now, and then it kind of fizzles off. As in contrast to that, you have Klonopin, which is like, it's going to help you, it's just going to be a little easier, and then it kind of comes down gradually. So Xanax is like boom, and Klonopin is like this. And Ativan's a little longer too, okay? Boost bar is often used for patients that need a little bit more help with their anxiety, and you're looking more concerned about their substance abuse issues. Other medication classes that they use: anticonvulsants, antihistamines, antipsychotics, and beta blockers. Anticonvulsants for anxiety, not so much. Antihistamines, so someone like, Benadryl, right? Benadryl will, for most of us, knock us out 80% of the time. 20% of the other time, you're going to never want to take Benadryl again because it's going to make you all ramped up. Okay? But there's antihistamines like hydroxyzine. Anyone heard of that? Atarax? That's a great medication for someone also that has some substance abuse problems that you're not really fond of giving them a benzo. And you have hydroxyzine and Vistaril. Vistaril is your capsule form. Hydroxyzine is your tablet form. So you'll see that sometimes. Why is this person taking an antihistamine? It's for the anxiety. And why would you use beta blockers? Beta blocker is going to help decrease the heart rate. So when your engine starts to rev and you start to get real anxious, think of beta blockers as like your restrictor plate when it comes to NASCAR racing. Okay, they won't let you go too far, too fast. It'll say, nope, can't go much farther than this. So that's calming effect. So of the classes of medication, a quick heads up is benzos, very quick onset, very effective, but there is a risk for dependency. We did talk about boost bar. Beta blockers are going to help with the hand tremors as well. You may have somebody that's taking lithium, right? And with lithium is a great medication, but sometimes it causes you to have hand tremors, like this. And they don't like that, but they like the medication. So they add boost bar to help calm with the hand tremors, okay? Slowly down the heart rate, and it's a great medication to kind of help you calm down. So the outcomes. So generalized anxiety disorder, you recognize the signs of increased anxiety and intervene before feeling panic attack. You can't stress this enough to your patients. I don't want you to come to me when you're in a full-blown panic attack and ask for medication. I want you to identify how you're starting to feel, okay? Because a lot of times they're going to get triggers. They're going to get like reminders that say, oh my gosh, I could see myself having a panic attack. That's when you take the PRN medication. You want to explain to them like, hey, let's verbalize a plan to respond to these phobias without developing a panic attack. Let's see, so we're going to work on with you, and we're going to help with this phobia of spiders or whatever. So, for example, somebody that goes in for exposure therapy who really wants to work on these phobias, they might show them a picture of a tarantula. How does it make you feel? Then they might graduate to seeing a video of it, to the point where they actually go to see spiders. And eventually, just like the EMDR kind of dampens that response, they're going to realize that they can handle it. With OCD, you want to maintain that anxiety level without using those OCD behaviors. So it's like you want to fight through those behaviors. Express to the person with body dysmorphia about expressing positive vomit image, saying that I am worthy. I do look nice, right? In trichotillomania, you want to make sure you're managing their stressful situations a little bit more, because that's a lot of time when they start picking their hair. Trauma-related disorders, we talk about PTSD, acute stress disorder, attachment disorders, reactive attachment disorder, disseminated social engagement disorder. The idea is there are so many different trauma-related disorders, not just, we think of trauma-related disorders, we think of PTSD. There's many more symptoms or many more different disorders out there. And I believe somebody in this group is going, in either the Tuesday or Thursday group, is going to talk a lot more about dissociative identity disorder, which is one of those disorders where you can ask other psychiatrists and they say that that is not a true diagnosis, and this is just kind of, it's not very highly supported. Just sort of formally multiple personality disorder. Okay. But those with post-traumatic stress disorder, these are the people like that we always associate as the military. They go through and come back with a lot of PTSD from what they experienced in the wars. But it doesn't necessarily have to be somebody in the military. People that have been abused, people have been experienced a majority of large range of different traumas in their life can struggle with this. Okay. So the events is persistently re-experiencing this. So someone like that just sees something that reminds them of what they experienced in their life, just brings it all out. It's like it's a reminder, and it's just like that constant always talking about it and thinking about it. These are the people that really tend to avoid these situations at all possible. Like I said, no, you're not going to have somebody that has PTSD really itching to go to see, Saving Private Ryan or something like that on a movie, because they don't want to be reminded. They know that their trigger is going to be. You must have 2 or more alterations in the cognition and mood in order to be diagnosed with PTSD. That means your concentration's not there, you have no interest in doing things, and you're hyper vigilant, like you're always on edge. So the smallest things will set you off. Just someone coming right behind you will just kind of, the startle response will be so much. You also have to have those negative thoughts and emotions, hypervigilance, and nightmares, okay? And then also the reckless behavior, feeling detached, and a decrease in memory. Like you're not able to remember different things. These symptoms last for 1 month or more after the trauma. You experience a trauma, and these symptoms will last for 1 month or more after that. In the past, they used to call this shell shock, for those coming home from the war. And it's always been associated with the military. And those who served with Iraq, freedom of enduring freedom, like they talked about 11, 20% of those at war struggle with PTSD. So just think about 1 in 5 people coming home from the war are going to be struggling with PTSD. And I did give you my example when I worked at the VA hospital when I watched 3 or 4 guys just jump to the ground after seeing a commercial for the military. It was quite alarming. In children, repetitive play of the trauma, they kind of continuously think about what happened. They socially withdraw, and they don't want to play with others. They feel guilty, angry, shameful, and oftentimes confused. Their moods can go up and down, fluctuate quite a bit with this, and that they feel that they're bad people because of what they experience. They get very irritable and aggressive, can't sleep, experience nightmares, decreased concentration, hypervigilance. Okay. Moving on to acute stress disorder, symptoms of acute stress disorder symptoms that are the same as PTSD, however, symptoms are time limited, okay? Basically up to 1 month after the trauma, okay? So this is something that you acutely get after the effect of after you experience what you experience for that 1 month period. That's that acute stress disorder, which turns into PTSD if those symptoms last longer than a month. Those risk factors are the early adverse events alter the DNA in our body as far as they affect our brain's ability to regulate stress response. We want to also think about the perinatal exposure to stress can influence later responses to stress and behavioral outcomes in the offspring. That's a lot of times it's really important for someone that is pregnant to kind of make sure that they're surrounding themselves with positivity and making sure they're kind of be able to not being in much of a stressful situation to begin with. Between the ages of when you're birth to 5 years old, this is that rapid phase of that brain development, and occurs leaving the child vulnerable to many adverse events. So like your brain is continuously developing, up from the birth to age of 5 years old. So it's a very important time frame in your life. Psychological risk factors. We know that the trauma interferes with the attachment between the infant and the caretaker, and also attachment issues in adulthood. Environmentally, toxic stress in childhood can affect physical and physiological health in adulthood. Now, PTSD is often an add-on as well to many different psychiatric problems, including major depressive disorder, anxiety disorder, sleep disorders, go all the way down. Because if you think about the symptoms associated with PTSD, you're seeing a lot of symptoms overlap with all other diagnoses. When you're assessing somebody, of course, doing that mental status evaluation, you also really, really want to assess for suicidal ideation. Okay? These are the patients that want things to end because they can't stop thinking about what happened in the past. And these are the patients that will often be very impulsive and do things. You want to really assess their support system. You want to assess, like, how do you have any kids at home? Are you close with your kids? Are you close with your family? Who can you reach out to and talk to if times are getting tough? A lot of times their coping mechanisms can be not so good, like using drugs and alcohol. A lot of times people that come home from the war like to abuse alcohol and drugs to kind of mask these symptoms. And they're trying to get more and more support groups for these people coming home, the military coming home, because they understand the importance of being able to have access to the EMDR, have access to different types of therapy, so that they can, live a normal life. Because some of the stories that you hear from these guys working, just by my time working in the VA hospital, I've talked to a guy that basically explained that because he was a smaller stature guy, what his role was, instead, like if the enemy is over here, he, instead of going through and walk, towards them, they would go under, they would dig tunnels under the dirt, all the way under, to kind of reset different messages or whatever, and then bring them back. So can you imagine being underground, digging trenches like that? It's like unreal, some of the stuff that they saw as well, that they explained to you. It's like, we're going to go back to when we're talking about how talking to somebody with anxiety directly, it really affects you, because you're like sitting there and you're like, oh my gosh, I can't imagine. And just by the information that they give you, so-and-so lost his arm and it was an IED and this happened and we had to do this and I was responsible for doing this, and this. And just sitting there listening, it's like, whoa, that's a lot. You feel it in yourself. You're like, I can imagine what these guys have gone through on a daily basis. All right, so let's see here. Just gonna move on from there. We just talked about a lot of these different treatments, and a lot of times the kids enjoy like the art and play and different things to help explain how they've been feeling. You'd be amazed at some of the pictures that I got from kids working with kids about what they, free text. We could draw whatever you like to draw, and some of the stuff that they drew is like, wow, it's horrible what they experience. Cognitive therapy, EMDR, and then we're going to talk about different medications. It would be the same situation, same types of medications we're using for anxiety in general, okay? Like the SSRIs, tricyclics. Now, we're going to move on and talk about alpha-2 like clonidine. Clonidine is a medication like, if you've ever heard of 10x, clonidine, right? Those are the two medications that help with like ADHD, help with that focus and concentration. Because remember, these guys really struggle with that focus and concentration, and they need something to calm them down a little bit. Okay? So that would be an option. Beta blockers like we talked about as well. So we're going to talk about reactive attachment disorder and disinhibited social engagement disorder, okay? Reactive attachment disorder is, I mean, you can take a whole class to talk about that. We're not going to go very in detail, but these are the kids that they consider RAD, R-A-D, reactive attachment disorder. Kids that had experienced a significant trauma in their life, okay? They can't really bond with people. There's no real loving anywhere. It's just, you know, because they think about it, they've been to different house to house to house to house, and no one really wants them, okay? So they can't have that attachment to other people. And this is also caused by like somebody that's born between birth to 8 months who has really no caretaker, so they don't have that bond. They don't know how to develop that bond. Very rare, maybe about 1% of kids have this. Okay. And then that disinhibited social engagement disorder are those kids that have no fear of coming right up to you, that you're in the mall and you feel someone on your leg and you're like, what is this? And it's some kid, you have no idea who they are, right? And it's the, you know, and the family's like, oh, no, he's just like that, you know, there's no shame there. There's no, it's just a problem with like, they have no problem attaching. They just want to, and they're also unfazed by separation either. Like you're going to go, we're going to do this. Oh, that's okay. You know, they don't have that engagement because they didn't have it as a child. Adjustment disorder, that maladaptive reaction to identifying stressors, clinically significant cognitive, emotional, or behavioral symptoms. Adjustment disorder is a good rationale for somebody that has not had that anxiety feel, those symptoms lasting 6 months. But you notice 4 months into it that they're struggling, you call it adjustment disorder. The same situation, adjustment disorder, where someone doesn't meet criteria for major depressive disorder, right? Same thing, adjustment disorder. Because the next time you see them, perhaps it might be the same, you know, you're building it up for that diagnosis. So if someone has a 3-month period of time where they're dealing with the stressor, but it's not been 6 months. This adjustment disorder could be a variety of different choices. Adjustment disorder with anxiety, depressed mood, all throughout. So someone who doesn't meet criteria, but you think might, or is in the middle of it, you call it adjustment disorder. There are things you can help with adjustment disorder. Typically, it's not medication. Typically, you attack with symptoms, like you attack those symptoms with different types of therapy. Individual therapy, family therapy, behavioral, self-help, all those different things. Psychopharmacology is in the bottom of the list, okay? Dissociation disorders, as the association protects against overwhelming anxiety through emotional separation. This is so unbearable for me that I'm gonna exit my brain, basically, okay? I'm gonna create disturbances in memories, consciousness, thoughts, self-identity, and perception. Okay, so decreased subjective distress of this trauma and protects the person from full awareness of the actual disturbing event. So when they start feeling like that, they dissociate. Okay, you might just see someone dissociate when you're talking to them, and all of a sudden their eyes go stare blank. But they're there. They're dissociated because they're experiencing those traumatic thoughts. 2 things to separate between: depersonalization and derealization. Okay, the depersonalization is that extremely uncomfortable feeling of being an observer of one's own body or mental processes, versus derealization, recurring feelings that the surroundings are just simply unreal or distant to you. Two other ways to determine this: dissociative amnesia versus dissociative fate. They talk about, when we're talking about amnesia, that inability to recall important personal information about the traumatic event, okay, or stressful event. You just can't remember the details. Dissociative fugue, as far as your sudden unexpected travel and inability to recall one's identity. Information about the past usually occurs after the trauma. This is when you are with the police, what happened, and sometimes you just might not realize. And dissociative identity disorder, this is when you have different personalities. And you travel from one person to the next, depending on how to deal with certain situations. So one personality will block access to the traumatic memories that you experience. And one thing I realized interesting, I may find out who this is, that Herschel Walker was diagnosed with dissociative identity disorder. I just saw he had a book on that. So extreme abuse, extreme trauma can lead to this as well. All right, so just enough time. Finish this up. Does anybody have any questions there? It was used to be called multiple personality disorder. It's a very questionable diagnosis. People don't really tend to even believe it. I could talk you one quick story about how people can remember things, like especially a trauma and stuff like that. Depending on certain things you have in your office can trigger somebody into a traumatic event, which you wouldn't even think about, or you would never know. I had a Purell kind of a hand sanitizer in my office, and the girl saw that and just lost it because the guy who abused her had the similar hand sanitizer in his room, or somebody with cologne. Certain colognes will trigger kids, things like that. So. Okay. Good. The key to this is talking about this question, talking about demonstrating selective inattention. So only certain things in the environment are seen or heard. So good. Very good. 18 months. This is also from the book here. 18 months as far as separation anxiety. It is tend to be normalized when normal part of development until you're at the 18 months as far as separation anxiety. Very good. Phobia. I mean, it's crazy how many different phobias are listed and categorized. Good. Which I still don't understand of why this is like this, because you would think that you'd be triggered a lot of times, but the more you ask your patients, the more you're going to realize that sometimes it just comes on. There are times, yes, that you get triggered, but the majority of the time, simply have no idea where it came from. And that's why it's terrifying for these, sometimes for these patients to go into, to concerts or public events, because how humiliating it would be to like get there and have a panic attack. So what we consider somebody that maybe has 4 months worth of anxiety, different symptoms, but can't diagnose them as generalized anxiety. So what would you say? Say maybe adjustment disorder with anxiety, with your anxiety. Great. So can you tell me a different, the name of a medication that works on GABA? What medication works on GABA? No? You want to take a guess? What are the medications we talked about that use for anxiety? There you go. Xanax. Xanax is kind of considered a what? Huh? Huh? Benzodiazepine, right. So benzodiazepines really work on the GABA, okay? Good. Good. So these are both good answers. SSRIs are the first line treatment for anxiety. Benzodiazepines are definitely used for anxiety, but they are definitely not first line. Okay. When we talk about treating anxiety, it's more long term, and remember we don't want to use benzodiazepines long term. That's more just an as needed basis. Very good. Very good.